Listen up.
HUS, hemolytic uremic syndrome. You got to remember the triad. Microangiopathic hemolytic anemia, that's MAHA, low platelets, and acute kidney injury. The culprit? Shiga-like toxins, usually from E. coli O157H7. It's all about that direct endothelial damage.
Then there's TTP, thrombotic thrombocytopenic purpura. This one builds on HUS. It's a pentad. You take that HUS triad and you add fever and neurological symptoms. But the villain here is totally different. A deficiency in the ADAM-TS13 protease. Two completely different mechanisms at play.
So let's put them side by side. HUS is a kidney problem, plain and simple, kicked off by that Shiga-toxin. TTP, on the other hand, is a full-body assault, multisystemic, all because of that ADAM-TS13 deficiency. You've got the triad versus the pentad. You have to know this distinction cold.
But here's the tricky part, what makes them so dangerous. They share these core features, MAHA, low platelets from consumption, and those fragmented red cells, the schistocytes on the smear. This very overlap is why being able to tell them apart, and fast, is a life-or-death situation.
Now, before we go any further, there is a critical procedural warning you need to hear.
Thrombotic microangiopathies are hematologic emergencies. Treatment initiation must not be delayed for confirmatory testing if clinical suspicion is high. You consult your institutional hematology protocols. Period. This is non-negotiable.
All right, with that understood, let's get into the clinical application. It's time to reason through some cases.
So, you've got a 6-year-old child. They've had bloody diarrhea, and now they're not making much urine. Labs come back, hemoglobin of 8, platelets down to 40,000. So, what is the mechanism here? That is classic sugar-toxin-mediated HUS. The toxin is attacking the lining of the kidney's filters, the glomerular endothelium. This creates tiny platelet clots, microthrombi, that act like little razors, just mechanically shredding red blood cells as they try to pass. The key here is that the damage is localized and toxin-driven. Excellent. Okay, next case. A 30-year-old woman shows up with the exact same labs, anemia, thrombocytopenia, but now she's also confused and has a fever. What's the mechanism now?
This is pointing right at TTP. The lack of that ADAM-TS13 enzyme means these huge, ultra-large von Willebrand factor multimers aren't getting cleaved. Instead, they act like sticky nets, causing platelets to clump together all over the body. You see, this shows the key difference. TTP is a systemic, multisystemic attack.
Okay, here's the question of the day, something that trips up a lot of people. What's the status of the coagulation profile, your PT and PTT, in both HUS and TTP?
They are typically normal, and this is a massive diagnostic clue. It's a key contrast with something like DIC, disseminated intravascular coagulation, where you'd see the PT and PTT are prolonged. Don't ever confuse platelet consumption with a true coagulopathy.
All right, to lock all this in, let's use a powerful visual mnemonic. Let's call it the barbed wire anchor.
I want you to picture the body's entire microvasculature as just one vast fence made of barbed wire. Simple enough, right?
Okay, let's break it down. First, the injury. In both HUS and TTP, those platelet thrombi make the fence broken and jagged. Second, the red cells. Think of them as balloons trying to fly through this broken fence. They get popped, shredded, and that's how you get schistocytes. And third, the all-important contrast. In HUS, that barbed wire damage is almost exclusively in the kidneys. But in TTP, that barbed wire is everywhere. The brain, the heart, all systems.
So let's bring this all home with one final directive.
If you confuse the triad with the pentad, or if you miss that the PT/PTT profile is normal, you are not ready. You need to master the ADAM-TS13 pathway. That is the standard.
Go.